Hi, welcome to episode 7 of UMD podcast. Episode 6 of UMD podcast. Today we have Dr. Howard Rosenthal from University of Kansas Medical Center. Thank you, Dr. Rosenthal, for joining us today.
My pleasure. Thank you. It's good to
Um,
be here.
we'd like to start off by asking you to briefly summarize your educational background and describe how you came to specialize in orthopedic oncology.
All right. So first of all, let me explain what is an orthopedic oncologist, because in all honesty, it's a fairly rare specialty and in fact didn't exist more than 30, 35 years ago. It's the specialty, a subset of orthopedic surgery concentrating in the field of cancer, most specifically sarcoma, which are cancers of the mesenchymal or the musculoskeletal system, but also we deal with developmental abnormalities of bone, and benign bone tumors as well as metastatic disease. I went to college. I got a degree initially. I started off with an interest in biomedical engineering. I wanted to make, and this may be showing my age or showing your youth, but I wanted to make the $6 million man. I thought that was really cool. If you don't know, the $6 million man was a television series of a test pilot that got in a crash and essentially or virtually died, and the doctors were able to put him together, and the key is make him run faster, see farther, be stronger, and so forth, with bionics, the incorporation of machinery into the body to create a better human. I really like that, and I started off my education in biomedical engineering. And then I think it was my third year, talked to my advisor and told my advisor what I wanted to do. And my advisor said, you have to be a surgeon to put those things in. And I thought that was a total shock to me. And I said, so I have to go to medical school first? And yeah, I did. So I went to medical school and then did a residency in orthopedic surgery. During that, I was doing research in biomedical engineering and cancer, and then did a fellowship at Sloan Kettering in New York in orthopedic oncology. There are about, at that time, and even now, there are about 6 positions in the country for the training of an orthopedic oncologist, which seems to be about right because these cancers are extraordinarily rare. There are about 80 different types of sarcomas. Sarcomas, again, representing those cancers of the musculoskeletal system. And of those 80, if you add them all together, they still represent less than 1% of cancer. So it's something that you just don't need a lot of us. So my practice, I've been in practice for 30 years. My draw area of patients is in about a 6-state region centered in Kansas City, which is why I chose the middle of the country, because I get the entire middle of the country. And I deal with patients all ages, pediatrics. My youngest, 3 months in utero, my oldest, 103. And I have the opportunity of operating on every part of the body from the top of the skull to the little toe. I probably just answered most of the questions you're about to ask.
Yeah, you answered a few. I was curious, what's it like treating such a small percentage of cancers? You must have like very highly specialized in what you do. And can you just talk to us a little bit about the process of
So it's a tertiary care consultant type of practice. Nobody comes in off the street and says, I have a sarcoma. Patients are referred through usually at least 2, sometimes up to 6 different physicians until they get to me. And the reason is because, again, of the scarcity of the diagnosis. Most doctors are not trained in sarcomas. If you look at, when you go into medical school and you look for sarcoma in your pathology book, I will bet you it will be in the last page or second to the last page, with the last page being a dedication or something. In other words, they're so rare that an average generalist will see 1 in a lifetime. The average orthopedic surgeon, who is the one they ultimately will get to may see 3 in a lifetime. So you have to have a large draw area. If you're practicing in Hays, Kansas, which is on the western Kansas side, you're not going to be a successful orthopedic oncologist.
So was there anything that drew you specifically to being an orthopedic oncologist? Like, do you like the fact that you're like one of the few, or do you find that to be frustrating where there's not really as many people who you could ask for a second opinion or keep up with, like, for the most recent information?
So great question. There's two components of the specialty. One is the surgery, and I should say that the primary treatment for sarcoma is surgical, unlike other cancers where the primary treatment might be chemotherapy or radiation. We do use chemotherapy, we do use radiation, but it's the surgeon that actually directs it. So surgery is the primary treatment. We are tasked with getting rid of the cancer and hopefully curing the patient. So you're dealing with cancer. I've also always been involved in cancer research, having done research before during medical school on the healing and repair and the genetics of DNA and carcinogens and so forth. But then there's also like I mentioned, the rebuilding or what we call limb salvage surgery. When I take a part out, I have to rebuild it. Now, these cancers are known, well, because of the rarity, and as I mentioned, most lay people have never heard of it. Most doctors don't experience it. There are no blood tests that code for a sarcoma. There are no symptoms. Most sarcomas are non-painful and do not exhibit any symptoms whatsoever. So the problem is by the time we get to see them, they are quite large. So the average size soft tissue sarcoma that I remove is about the size of a cantaloupe. The average bone sarcoma that I remove is at least 1/3 of the entire bone. So if you have a sarcoma of the distal femur, the end of the thigh bone, you have to resect not only the thigh bone, but the knee, the quadriceps, the hamstrings, all the muscles, the ligaments around the ACL, the PC. It's like the ultimate of sports medicine. You're resecting everything, and then you got to reconstruct it. And since most of these cancers occur actually in younger people, you got to reconstruct it in a way that, number one, the patient can get back to a normal, young, active sports life where they get to do the things they want to do, and with a mechanism that hopefully the way that we reconstruct it will last their entire lifetime. And that's how far we've gotten in this 30 years, because again, 30 years ago, there was no such thing. I have the privilege of being in this specialty, watching it, the entire history of it from infancy to current. And I can't imagine what the next 20 or 30 years are going to be. But, we've gone to the point where patients don't expect that they don't just expect their cancer to be cured. They expect their cancer to be cured and with full, complete function, both in function as well as in appearance. And we're able to do that to even to me, is a surprising degree.
So I actually had two questions. I know you said that sarcomas are extremely rare and therefore there aren't that many fellowships. So would you say to someone who's interested in orthopedic oncology that there's a lot less work to go around, or that they should supplement orthopedic oncology with something like a joints practice or something else?
Right. So my answer to that is you got to love what you do. Whatever you want to do, you got to love it. It's got to be an inspired feeling that you are going to love it. People are asking me, when are you going to retire? And in all honesty, I still love operating every day. I still love talking to the patients. I have no desire at all to not do that. So even though there may not be a lot of positions open, and I'll explain what I mean by that. I just hired a partner, my first partner I've ever had, in the two years ago. And in that year, there was 1.5 positions open in the country. Mine, which was a full-time position, and the other was a half-time position where the rest of their time would be doing joints. Most of the guys that do come out, and that was it. So anybody else that graduated did not get a job in that field and are probably doing usually total joints or trauma. Most of the time, the setting, and most people do go into academia in orthopedic oncology, Most of the time they're told by their university or their hospital, well, you'll do the joints, the joint replacement and trauma as it comes along, because if you can do orthopedic oncology, you can certainly do all that, which is obviously true. But if it's the problem though, is because these surgeries are extremely complex. And in all honesty, I'm trying to figure out how to say this nicely. We say things differently in the operating room than we would on a podcast. It takes a lot of guts to do what we do. We're taking people apart and putting them back together again with implants that have machinery in them and so forth, all without infection and all the complications that can ensue. So the problem is, unless you do it every day, you're going to get scared about doing it. So if you're doing, joints every day or trauma every day, and then your tumor comes along and it's going to go to you, but you haven't done one of those in a while, or maybe you have never seen one because of the rarity, you're going to be a little hesitant. And most people, I think the number actually is about 60 to 70% of the fellows trained in orthopedic oncology end up not doing orthopedic oncology. There are about 100 of us in the country, 120 of us in the country, of which only about 40 do orthopedic oncology as the majority of their practice. And of those, there are really only 20, and I'm one of those 20 that do it full time and don't do anything else. So the numbers are extraordinarily rare. And by the way, with those numbers, there are probably too many of us right now. But as I say, if you want to do it, because you get a fulfilled life doing it, and you make a big difference to your patients.
So going back to what you're saying about how you kind of got to see a lot of these improvements specifically to your field, but I'm assuming just also the whole field of medicine, how do you keep up with it? And do you have somebody like come in and teach you how to put in a new implant, or if there's a different way to do a procedure? How exactly do you stay in the know-how for everything?
Well, in all honesty, a lot of it is, I want to say, you make it up. All right. So when I first started, there was no such thing as a distal femur replacement prosthesis. The example I gave of replacing the end of the thigh bone, the knee joint, the ACL, the PCL, the MCL, the whole thing. There's no such thing. So one of the reasons I chose Sloan Kettering as my fellowship is it was the fellow's responsibility to design a prosthesis. And I spent the entire time there developing and designing, and again, having my biomedical engineering experience designing prostheses. When I started, and we did fantastical things with these. When in the probably early 90s, they started becoming customizable. In other words, I would call the company or a company, and I would say, hey, I need this prosthesis. I would send them the tapes from the CAT scan. And in about 6 weeks, I would get a prototype of this thing, usually made in wax, and I would sign off, and then they would actually give me the real thing. And I'd implant that. Well, the problem is you're waiting 6 to 8 weeks while the patient has cancer. So we started doing chemotherapy between the time, realizing that was actually a good thing. And that gave us a little more time to make the prosthesis. Then the next generation, we came up with what we call modular prostheses. In other words, parts that could be assembled at the time of surgery to customize it to that patient. I designed, for example, the third generation segmental prosthesis, which essentially can replace, if you came into my office or operating room tomorrow with a cancer anywhere on your body, I could replace it and reconstruct it that tomorrow with all of the instrumentation I have in my operating room. And I don't have to call for parts. I don't have to call the company to do it. It's all modular, customizable at the time of implantation. So it's, when I say you make it up, that's honest to God the way it started. You use principles that you know about and you expand upon that. So for example, we're talking about, in all honesty, it's easy to replace a bone with a piece of metal. It's not so easy to attach a muscle to that piece of metal and have the metal or have the muscle grow into the metal. But now we're at the point where not only are we doing that, we're actually inducing the bone to grow in and replace the prosthesis. So we're truly making an organic, this is Terminator stuff, by the way. We're making organic replacements of body. Other options include bone transplantation. I'm talking about living bone transplantation. So when the guy needs a heart transplant, there's an orthopedic surgeon there also. He's usually last in line, by the way, but he takes the bones out. And if I need a bone, I get it. And, you know, I have to match it and the whole thing and can replace it with a living bone donor. We have other biological solutions. I don't know why my iPhone's doing that, but that become very, very innovative in nature. Some that you would never believe, even if you saw the patient. Just as an example, I have a patient who I did many, many years ago. The procedure is called a rotation plasty. So you can, as I say, you can reconstruct the parts very well. But I also told you that the patients can be of various different ages. So what if you have a 9-year-old and I've just taken this growth plate out? That 9-year-old's got, you know, they're theoretically 2 feet of growth left in that one extremity. How can I make metal grow? Well, I can always bring the patient back to the operating room every few months and add parts. But boy, doing that to a 9-year-old until they reach skeletal maturity every 3 months during their entire childhood with the risk of infection and so forth, not a good way to go through life. But we now have technology of what we call non-invasive expandable prostheses. I bring the patient in. In fact, I do it every month. And I almost have the patient do it themselves, where they wave a magic wand over their leg and it emits a radio frequency that goes to a motor on the inside of the prosthesis with a gear mechanism, and they lengthen themselves. So they grow, their prosthesis actually grows. The rotation plasty, you're gonna love this and please don't faint, but imagine that 9-year-old with the tumor around the knee area, and I have to take that out. Okay, I've also taken out the growth plate of the femur, the growth plate of the tibia. So there's a huge limb length discrepancy. And am I going to really get that 9-year-old to do the physical therapy that's going to be required? Probably not. So although the technology is there to do it, the patient may not agree or be able to. And you can't tell the parents you have to force them, because this is a parent of a child with cancer. And they're going to be as loving, as sweet as they possibly can, and certainly not cause the patient any pain. So rotation plasty is you do a double level amputation. You amputate the leg at upper thigh level, then you amputate the leg at the mid shin level and take out the middle. So now you've gotten rid of the cancer, and then turn the leg around 180 degrees so that the foot points backwards, reattach the tibia to the femur, and you do it in such a way that the ankle is now the new knee, because if you think about it, they run in the same plane, but you put it longer where the contralateral or the other non-affected knee will be at the end of skeletal maturity. And then you just put a big platform onto their foot, just like guys with, you know, those little stilts when they're painting their house, and they have ultimate function. And I'm going to tell you, you may have seen one of my patients, because there's a ballerina, and she's given me permission to use her name even, but she's a ballerina, she's a dancer, and she is featured in the Apple Watch commercial as doing ballerina stuff, dancing. And unless you knew exactly what to look for, you'd never realize that she's a rotation plasty patient. So these innovative ideas and concepts, which are developed essentially what I'll call personalized medicine, this is what you, the patient, needs at this time to function the best, is really what it's all about.
Wow, that's the ankle to replace the knee is like ingenious, and I've actually heard of it. It's a very cool operation. I had 2 questions. One was, on like a weekly basis, how many surgeries do you do because of this small niche? And the second question was, what are the implications for normal orthopedic surgery? Since the technology has gotten so good, would you use any of these techniques on, let's say, like a wide receiver for a football team if he tears his ACL? I know you can reconstruct an ACL, but would you ever use these other innovative procedures?
So in answer to the first question, how many procedures? I recently have lowered my volume for other personal reasons, partly because I got a partner also. But I was doing about 15 surgeries a week and seeing 100 patients a week. Now remember, my catchment area is a huge portion of this country. You know, my competition is essentially Mayo up in Rochester, Minnesota, and MD Anderson down in Houston, but I get everything else, you know, around the whole mid portion of the country. In terms of football players with ACLs, I'll say personalized medicine, because my partners, well, we are the official orthopedic department surgeons for the Kansas City Chiefs and the Royals. Okay, so if you ever see one of the Chiefs go down and develop an osteosarcoma on the field, yes, I will be out there. So far that hasn't happened, although we've had a couple that have developed and I've been there, but they have to function at a different level. So if I'm putting this remarkable machinery in their leg and they're going out on the field and saying, hey, you 250-pound brute that really doesn't care about anything other than putting me to ground, that's going to put a pretty significant risk to that prosthesis. We could do it, but you got to think of ramifications of complications.
For sure. Just to continue the question, so what's how sturdy or how strong are these prosthetics? And you gave the example of the limb lengthening in like a 9-year-old. What's that 9-year-old's future looking like?
So I don't restrict activities at all. If the 9-year-old wants to play soccer, have a good time, that's what I'm doing it for. I definitely have patients who have played high school level football and basketball. I've had mountain climbers, I've had marathon runners. I let them do anything, because the reality is you're doing the procedures to give them back their life. I could do a formal amputation and still be successful at getting rid of their cancer, but they're going to lose something in terms of their function and activities. Now, my teacher forbade them from doing those kinds. They said, you have to live a sedentary life. So you have to have a desk job, you can't do sports and all that kind of stuff. But with the prosthetics becoming so good now, we are not seeing any complications due to the prosthesis. So I don't restrict activities at all.
Okay, so I had a question. It's a little bit unrelated to what we were just talking about, but earlier you were talking about how the tumors that come to you are usually, you know, because there's no symptoms, it's like usually pretty far along. And so I was just wondering what the role of staging and grading is kind of in your practice, like how much you use it, what you think about it, and if you could just explain it a little bit.
So absolutely, we stage every patient. We have a team in our sarcoma program. We have every other week sarcoma tumor board, which is attended to by about 30 people and from all different aspects of the sarcoma team. So I have a medical oncologist whose primary focus is sarcoma chemotherapy. I have a radiation oncologist, primary focus is sarcoma. We have physical therapists. We have pediatric oncologists. Again, all whose primary focus is sarcoma. In that meeting or part of our staging studies, when I first meet the patient, yeah, I'll get studies to stage the patient, make sure these like to spread. If they're going to spread, they're going to spread preferentially to the lungs. Well, if they spread to the lungs before I get to do their surgery, then their surgery is probably not going to help because it's already in their end organ or more vital organ than their knee. So in that patient, that would change. We would definitely do chemotherapy first to try to rid it of the lungs. Now, let's say the patient has 4 nodules in the lungs and 3 of them are responding, but one's not. I may say, okay, we're going to do a thoracotomy or take that tumor out of the lung. And again, we may do all of that before doing the extremity surgery, because you got to go with, you know, the most important part at that time. So every patient is staged. The grade of the tumor is based on the aggressiveness of the individual tumor, the stage basing on the prognosis and extent of spread of that particular tumor.
That's all very interesting. Going back to what you were saying about how you have the whole board, so would you say that that's like really a different type of community, considering that there's so many, like so much less people in your niche than like other types of boards for other like specialties that happen to be more widespread? Like, would you say that like you have closer contact with these people and coordinate with them more so than other people would, or is it about the same thing, just on a smaller scale?
It's on a daily basis. We're a team. So I may be the head of that team and the chief at that time, but we will always all be in constant communication with each other. And it's very, I mean, we're friends. I think we've been doing it for a long time. So, you know, if Ben, my medical oncologist, has a question or a need on a weekend, you know, he has my cell phone number. He's going to call and I'm going to answer. And it's part of it. It really is part of a team. How it works, I'll tell you that when hospitals are accredited by the national or federal organizations, our sarcoma board was cited by the American College of Surgeons as to be the top tumor board, and I'll call it the light onto the nation for how a tumor board, not just sarcoma, but a tumor board should be run. And the way we run it, in all honesty, is we have to all agree with a proposed treatment, or we'll get a second opinion before we're going to offer that to the patient. We all have to know that we are going to be successful in that treatment.
I was curious, you mentioned before when Sam was talking about technological advances, I was curious, have you been a part of, or are you a part of any clinical trials? Are you trying anything even newer or more up to date than even, I don't know, we spoke about before?
Sure. So we are part of an organization called SARC, SARC, which is it's extremely exclusive, and it's a worldwide organization that provides access to clinical trials for sarcoma. And I think there may only be 20 centers in the entire world, and you have to have certain qualifications for that. And we have that, so we're a member of SARC. So yeah, and our hospital is an NCI designated hospital. So we have access to pretty much every clinical trial in this country and even worldwide. And we participate in virtually all of them. We do have in-house surgical clinical trials. In fact, I'm looking at 2 right now where we have over 100 patients enrolled. And then we present those at meetings. So it was funny, I didn't want to say this, but when you asked at the very beginning, you know, do I go and learn from others? Sure, but actually I teach the others. We go to the meetings and present our techniques and options. For example, we used, and we're the first in the world to use, something called CyberKnife. CyberKnife is stereotactic body radiosurgery loaded onto a robot that can track motion in real time and deliver a beam of radiation to an exact point within 0.3 millimeters of where I want it. And it's a surgical procedure, even though it's radiation. And we are the first sarcoma group in the world to do that. So I was getting consults from Turkey and places in Europe for patients with non-resectable tumors that we treated with the stereotactic body radiosurgery, CyberKnife. By the way, the technology is so good that the patient, it's a very high dose radiation. It's delivered in a very defined area. But what if the patient coughs and moves? This is in real-time tracking. It's not gated. It's not, you know, every 5th shot is going to hit. It's real time. So if the patient is moving, the robot will actually move the patient. So we would tell the patient, you're going to be locked in a room with a 9-inch metal door that's made of lead that is locked from the outside. You cannot escape. So if you run around this room, we're still going to catch you or your tumor. And we presented that at one of our international meetings, actually. And some of what I looked at is those sarcomas that were unresectable and non-responsive to radiation. So for example, chondrosarcoma is a cartilage malignancy. Nobody's going to dream of doing radiation for that because the tumor doesn't get touched by it, doesn't get affected at all by radiation. And we showed equivalent curative results using this technique with no surgery. So yeah, it's very, very innovative. You gotta have guts. You gotta try the right thing. You gotta do it for the individual patient. You get to know your patients.
Would you say that's like one of the things you find most rewarding about your specific field of medicine is just like how you get to really have, like, obviously every doctor has an interpersonal relationship, but you get to track their progress and I guess just really talk with them through some of this. And that's kind of another follow-up is like, how in depth do you go about procedures when talking to patients?
So the main thing is you have to care from the inside. You can't just put on it. You gotta truly care. I'm going to answer this question since I'm assuming I'm in a group that will understand what I'm saying. I'm the president of our synagogue. I gave the Yom Kippur appeal this year. I give this talk whereby how do you say thank you? Okay, and if you teach your children, if somebody gives you an apple or a piece of candy, you say thank you, and it becomes remote. Not remote away, but it's a moat. It's a natural response. But how much does it mean? The thank yous that I get are a nonverbal thank you. It does not require a word. And most of the time, I used to say and I teach this to the residents, that you have to be able to determine the patient's nature based on you've already looked at your x-rays, you know what you're going to be telling the patient, but you have to know how they're going to respond in order to explain it in certain ways. In other words, if I go into a mother of a child with cancer and say, hey, listen, I'm gonna turn your foot on backwards, they're gonna leave before you even get a chance to explain anything. So you've got to be able to judge personality and character. And I say, and you have 6 seconds to do it. And I've proven this many, many times. By the time you walk into the room, you have 6 seconds to determine a patient's nature through their facial expressions, through the way they're sitting, through everything. And now you're doing it, by the way, with a mask on. And I don't think it's changed at all. I think you can still tell everything about a patient with their expressions through their eyes. So it's the same with thank you. When I hear a thing, it's delivered through their facial expressions, their eyes, and mostly a hug. And in all honesty, the father of the patient, the mother's great at hugging. Mothers hug. Fathers don't do that. But a father hugging me in his thanks is something that is a heartfelt thank you very much. And that gets you. And you got to care about you got to really care. You got to understand it. I cry with patients. I cry when I hug patients. I get extraordinarily excited at their 10-year anniversary. I have a gong in my office with their 10-year anniversary. They get to ring the gong, and I'm typically so much more excited than they are because I know what could have happened, in those ensuing 10 years.
And does that ever like weigh on you emotionally, just knowing that there always could be something that goes wrong? And on top of that, just how you were talking about your volume before, like 15 surgeries a week, 100 patients in a week, that like you're always needed. Does that ever like make you anxious or just feel like a burden on your shoulders that you always have to be around for all of these people?
Yes. My wife and I's first vacation Well, I'll put it this way. Our honeymoon was in our 18th year of marriage. We have never taken a vacation more than just a few days, which is extremely rare that we even can do that. And here's the clincher. Your timing is absolutely perfect because I just made flight reservations. We are going on a 3-week vacation that I would have never ever dreamed of even 2 months ago. Never would have considered it because of exactly that reason. You have to be. I've been on call for, it's the 24/7, 365 times 29, for a long, long time. And you got to have that phone with you all the time, whether you're in the country or out of the country. Thank God we have national, international meetings, and thank God our international meetings are always in extraordinarily nice places. So I've traveled the world for these meetings, and I've been able to, my wife and I consider those our vacations. But we try to think of, hey, where should we go? Where can we go on a vacation? Well, we've been there, Hong Kong twice, Singapore 3 times, those kind of things. It's got to be fulfilled. Love it.
Dr. Rosenthal, I had a quick question going back to speaking with patients and interacting with patients. When you tell a child or you tell a patient that he has to have this and that surgery, and hopefully you cure the cancer, and then even if you do cure the cancer, there's still going to be months and months of rehab. What's that like exactly?
Right. So at one of the earlier visits for the patient, let's use the osteosarcoma, which is the most common of the primary bone cancers. I'll discuss the fact that you're going to get chemotherapy. That's going to take about 3 months. Then you're going to have surgery, and that's going to be, let's say, a month. It's not that long, but with physical therapy and so then you have another, usually 3 months of more more chemotherapy, and then 3 months of other tests. So it's a good 9 months of a significant alteration of life. For the kids, almost every one of them stays with their class. In other words, they don't lose their grade. And with adults with jobs, very few of them have to quit their job, that they're able to continue. Now, there's a lot of missed days and everything, but the teachers in the schools work great with us. The interesting, a little bit of the fun part that I have with this is because it's so exotic, every case becomes a newsworthy thing. So, either the patient is on the news, or the crucial catch patient at the Chiefs games, their face is on every stadium. They get to be in the front, and I get to be with them. I get to throw out the first pitch at the Royals games. My kids get to be on all of the bases and all that. I get to go out to a restaurant or something, and people say that's Dr. Rosenthal, and that's sort of fun. That's the fame kind of stuff because people do know.
I had a quick question actually. So you said, you get really involved and attached with the patients. Is there ever like a time where, because I know these treatments, they sound like they're very expensive, when insurance is ever an issue for paying for the treatment and the patient is unable to get it?
So the good news is number one is I have what I call my research and pediatric oncology fund. It's purely mine. It's my money. It's something I just put into from other things that come along. If I'm doing a presentation for a company and they pay me, it goes into that fund, and that fund actually goes to pay for kids without insurance, to pay for their treatments and everything. The reality is because there are no other, when you pay your premium for your health insurance, they are obligated to provide you care. If they don't have the ability to provide you care, they still have to provide you the care. So insurance is virtually never a problem for us. because all insurance companies will say, hey, Rosenthal, can you do this even if you're not in our network? Even to the point, our biggest problem, in all honesty, is Missouri Medicaid. Medicaid being a state program to indigent people in their state. Well, I'm on the Kansas side. Kansas does not accept Missouri Medicaid. However, and Missouri Medicaid will not allow a patient to go to Kansas, but they do. It's an exemption. So we really don't have problems at all with insurance. Thank God. My partners do.
So this question is a little bit unrelated to what we were just talking about, but going back to the like new technologies and stuff, have more recent just general technological advances, like especially 3D printing, has that made a very large difference in the time frame? Because you were talking about the prototyping taking like 6 weeks. But I know my cousin, he's starting to make prototypes and stuff for animals, and he said that they could do stuff that would normally take weeks like that typically in a matter of days. Is that something that's starting to be implemented more and more?
Well, I just made and implanted a 3D printed pelvis last week. So absolutely. Yeah, we're doing 3D parts all over the place now. And the company that I work with for that, when I give them the tape, the CD, it's made off of a three-dimensional X-ray set, which is typically a CT or MRI scan. They will actually have the 3D image on my phone, on my cell phone, within 24 hours, and then usually 1 to 2 weeks for the actual either model or implant. So I'm working with, we're at the, again, infancy of this, but what we're working on now is and I'm particular, I want my tumors to be yellow, because the tumor, the ribbon for sarcoma awareness is yellow. I want my artery to be red. I want my vein to be blue. I want my nerve to be white. I want my bone to be bone. In other words, let's replicate the body as perfectly as we can. So it's not just 3D imaging, it's being able to plan the surgery using these 3D models that we'll get before we even get the implant. Yeah, so in fact, when you said that, I was looking, I don't know if you looked at me, moving my head because I brought the model home, but I think I brought it back to work yesterday. So.
Dr. Rosenthal, I think I have one last question and then we'll wrap it up. So you mentioned much earlier on in the podcast how your dream was to create the first like bionic man almost. So my question to you, through all this limb rebuilding and all this amazing technology that we have these days, do you feel like you've almost fulfilled your dream?
Well, I can direct you to a YouTube site that I did not create. It was a patient of mine of his own desire, and it's public domain, so I can tell you it's search YouTube for, I think it's called Rosenthal Cancer Video. And you have to be careful because there's a few others, but Rosenthal Cancer Video. And it's a guy that I took out. He had a scapula sarcoma, and he was an athletic trainer, by the way, and he's still an athletic trainer. And I took out his entire scapula and proximal humerus, the upper humerus of the entire articulation, and did I think he was a 3D modeled total scapula, reverse total shoulder, proximal humerus replaced. So I reversed the ball and the humerus to give a better lever arm. And on that video, you will see him lifting weights that you could never imagine with that arm. Rosenthal Cancer Video. And I did not do that. He did it. But that tells you how, he's a $6 million man. Maybe I think I got a bargain at it. I don't think it cost $6 million.
Wow, that's amazing.
Yeah, that's incredible.
That's incredible.
I wonder if he has like a advantage since the muscles are changed in his arm when he's lifting weights.
Well, the reality is the more you put your physical therapy, your directed physical therapy into it, the better you're going to do. It's the patients that want to be involved in the care that always do best, versus doc, just fix me up and I'll be great. I want you to be part of your care. I love when patients get, tell me exactly why you're doing this. I love these kind of conversations with patients because, it's naturally exciting to me, but it's fun when it's exciting to the patient also.
Mhm. Well, thank you so much for meeting with us and agreeing to be interviewed. It was one of the
Thank you.
interesting interviews for sure.
I agree by far. We really appreciate it.
Okay.
Thank you so
Do
much.
what you love. That's the bottom line. And be the best at it. What I tell my kids, you want to be a trash man, a garbage man, fine. Be the best one there is.
Yeah, love that. My dad says the same thing.
Yeah.
All right, thank you.
Thank
Thank
you.
you so much.